Good afternoon, everyone. At the outset, I must thank organizer for organizing such a beautiful academic event for the students. And the students are the pillar of our specialty. So more they educated, more their competence, our specialty will grow. So today's my talk on scoliosis. My talk will be confined to mostly clinical aspect of scoliosis, and it's a radiological evaluation, functional evaluation, and decision of a protocol of management of scoliosis. These are my outlines of my presentation. So, Scoliosis Research Society describes scoliosis as a deformity where the spine is deviated laterally with a curvature of corpse angle more than 10 degree. This is a deformity which is remain very silent unless otherwise very severe, causing any disfigurement or any visceral compromise. Though it looks like a uniplanar deformity, actually it is a triplanar deformity where you will find deformity of in coronal plane with a lateral deviation of the spine. Transverse plane, there is a rotation of the vertebra, which is the real cause of the deformity. And in thoracic curve, you will find sagittal plane deformity presenting with a hypokyphosis. So broadly, the scoliosis is classified into two groups: structural and non-structural scoliosis. Non-structural scoliosis, they are mostly temporary curve which can be corrected once the underlying cause is eliminated. Where the structural scoliosis, they have a structural defect in the vertebral column which gives rise to deformity. These are further classified into idiopathic, congenital, neuromuscular, neurofibromatosis. These are certain causes which can give rise to structural scoliosis. Other way, depending on the severity, can be classified into mild scoliosis, moderate, and severe scoliosis. Out of that, idiopathic scoliosis is the most commonest variety of scoliosis, which constitutes around 80% of all deformities. This deformity is insidious in onset, progressive in nature, mostly painless. They can be further classified depending upon the age of onset: infantile, juvenile, and adolescent idiopathic scoliosis, the most commonest one. And today's discussion is on adolescent idiopathic scoliosis. This adolescent idiopathic scoliosis again are three categories depending upon location of the curve. It is thoracic varieties when the apex of the curve is at D2 to D11 level, and thoracolumbar varieties where the apex is around D12 to L1, and lumbar scoliosis when the apex is at around L2 to L4. The curve in idiopathic scoliosis is little bit moderately flexible in comparison to other scoliosis like congenital scoliosis, where it is a stiff rigid curve. This idiopathic scoliosis, the overall prevalence is around 0.47 to 5.2%, with a slight increase in prevalence in case of girls. And of course, the rate of progression of scoliosis in girls are more in comparison to the boys. Usually, a idiopathic curve which is thoracic located and deviated towards the right, that means apex toward the right side. And 10% cases only have a symmetrical curve with S-shaped. Rest 90% are C-shaped curve, which are very dangerous and causes body asymmetry. If you look at the structural changes to the scoliosis, what happened? There is lateral wedging of the body of the vertebra on the concave side. There will be always associated with vertebral rotation. This vertebral rotation is the real cause of deformity. If you see here, the spinous process will be displaced towards the concave side, and the transverse process will come towards the midline. So this rotation of the vertebra is really cause of the deformity or disfigurement in scoliosis. If you look to the pathogenesis, there are a lot of hypotheses about that, why the vertebra is getting deviated, though there is no underlying cause. Actually, it has been seen that there is a growth difference between anterior column and posterior column of the vertebral column, and as the anterior column grows faster in comparison to the posterior column, the spinal canal lying behind remains short, At that, to adjust the lower vertebra, there occurs a rotational lordosis, and that differential growth between anterior column and the spinal canal that create a relative shortening of the cord that causes tethering of the cord, and that could be the possible cause of etiopathogenesis of AIS. So this is a diagrammatic presentation, graphic presentation, where it has been seen that the shortening of the spinal canal with respect to the vertebral column, as it increases, the rotation of the vertebra gradually increases. This is the difference between the shortening of the canal with respect to vertebral canal. As it grows, increases, the rotation of the vertebra increases. So that is the one of the major cause of rotation of the vertebra leading to severe deformity. What is our role as a physiatrist for the management of scoliotic patient? So as a physiatrist, we have to take a proper history, diagnose the condition, what type of scoliosis it is, and what is the type of curve, assess the curve properly, and as per the curve, plan the treatment protocol, and as per the assessment of the curve, decide what type of protocol, whether you go for observe or you plan to give a brace or refer for surgery, monitoring or follow up of the curve, most important detection of the red flag signs, when you should refer the patient for surgical intervention or other specialty. Coming to clinical examination proper, in here we'll just examine scoliosis as we examine other neuromusculoskeletal conditions, the heading of inspection, palpation, movements, measurements, special tests. This way we'll examine scoliosis. So coming to history, you should ask why the patient has reported to you, whether because of deformity, because of back pain, or because of compromise in pulmonary function. When the curve first noticed and by whom, and at what age the curve onset was detected. That's give you idea about how rapidly the curve is going to progress. About the growth spot, when you be dealing with a girl, when the menarche started or when the voice change started, that will give you a clue that at the maturity status of the patient, and you expect the progression of the curve. The deformity is whether it is progressive or it is remain static, any neurological symptoms associated with any previous history of treatment. All these history you have to take. After taking history, you have to see any gait asymmetry, whether the child is walking with a symmetric gait or asymmetric gait. Then for examination, you expose whole the back of the child. Of course, for girls, you have to have a lady attendant. Look for the surface anatomy in sitting posture as well as standing posture. Examine the patient on frontal plane as well as in sagittal plane. Coming to inspection part, you have to look for any trunk asymmetry with respect to head, with respect to shoulder, scapula, and a pelvic asymmetry with respect to any presence of any deep flank crease, what is the level of iliac crest, whether any obliquity of iliac crest is there or not, and location of the curve. On inspection, you can see what is the extent of curve and which side the convexity is there. These things you have to see in inspection part. And in any asymmetric shoulder level or poorly compensated curve present with a asymmetric shoulder level, you will find that on the convex side, the shoulder level will be a little bit higher, and the scapula will be rotated forward and outwards. The lower pole of patella is deviated toward the convex side. If you go back a little bit down, you will see that the flank creases will be very much prominent. There will be exaggerated on this flank crease, and you will have a bulging of the paraspinal muscle on the convexity side, otherwise called Checklin signs. So these are features of at the shoulder level. You come down to hip level, you will find there will be obliquity of the pelvis, mostly in the lower lumbar curves, and the anterior superior iliac spine will go up toward the concave side. So obviously anterior superior iliac spine and posterior superior iliac spine will be at different level. So all these inspectory findings you have to confirm by palpation, then appreciate the curve status, how it is, how much the extension, whether extend is a thoracolumbar curve, which side. Clinically palpate the whole spine, along the whole spine, and see where is the clinical site of apex of the curve. Then next part is assessment of movement. That's very important. You have to check for forward flexion, rearward extension, flexion to right, flexion to left, that give you an idea about the flexibility of the curve. So sometimes confusion arises which one is the primary curve, which one is secondary curve. When you go for lateral flexion, if the curve size diminishes, that indicates that's a secondary curve. If the curve persist with the same magnitude, that indicates it's a primary curve. The next part is the measurement part. The measurement of iliocostal distance, that is distance from iliac crest to the 10th rib, that's iliocostal distance, and chest expansion, that certain extents give you idea about the severity of the curve. Scoliometer some people use for measurement the severity of the scoliosis, but that is not so commonly used when you have a facility of taking X-ray. Then neuromuscular examination is a must along with the musculoskeletal examination. Look for any associated pain, any decrease in strength, endurance, balance, coordination problem, any changes in sensation, any changes in reflex. That give you an idea of any underlying pathology or any serious cord compression because of severity of the curve. You should look for neurological markers like any midline skin defect suggesting a spina bifida association, capsulate spots may be associated with neurofibromatosis, any cavovarus deformity of the foot, or any asymmetric abdominal reflexes that suggest a underlying syringomyelia. So those pathologies could be a cause of this scoliosis. Next, coming to special test, Adams test is the most common test is used as a screening procedure for evaluating scoliosis or detecting scoliosis. Ask the patient to lean forward, bend forward. If the curve abolishes, that means it is a non-structural scoliosis. If the curve still persists with prominence of the paraspinal muscles and the ribs on the convex side, that indicates there is some amount of rotation and fixed deformity is there. So that is a very sensitive test, is a screening test to diagnose scoliosis. Other special tests includes lungs function test, cardiac function test when the patient is having severe thoracic curve with any pulmonary compromise. Yes, the different assessment systems, we have functional assessment system, we have radiological assessment system. Functional assessment systems are very few, like Scoliosis Research Society, SRS 22nd, that's a functional assessment system that has few domains like pain, then self-image, function, then any self-satisfaction, the treatment, mental health. These are the 5 domains under which the functional assessment can be done in a case of scoliosis using SRS 22nd score. Besides that functional assessment, radiological assessment plays a cornerstone or important role for diagnosing the scoliosis as well as see the severity of the scoliosis. For that radiological assessment, you have to take anteroposterior view of the whole spine with a single film. So entire spine should come on a single film, including the pelvis and both the hip joint, and lateral view sometimes required to find out any associated hypokyphosis. From this anteroposterior view, the important things to be marked here is the Cobb's angle, by which you can, as I said, the definition is more than 10 degrees. So Cobb's angle is the measurement, the important part, and besides that, research science also will see from the AP view to see the to prognostify the progression of the curve. So Cobb's angle, I hope all students must know about the Cobb's angle. This is here the angle between the two tangents at the end plates of the upper vertebra and lower vertebra. If in case of severe curves, this tangential line can dissect on the same film, and this is the Cobb's angle. When you are dealing with the obtuse curve, a small curve, they may not cross sect in the film. So that time you have to draw a perpendicular line to upper tangential line and perpendicular to lower tangential line, and this is the Cobb's angle. Same principle can be used for a double curve also. The same Cobb's angle can be used in the double curve. There are another method of measuring Cobb's angle here, that you draw a horizontal line to this oblique line, horizontal line, and another horizontal line to this lower oblique line. The angle formed here is the alpha angle, and here is the beta angle. The addition of alpha plus beta is the total corpse angle. So this is another method of measuring corpse angle. Nowadays software is also available for measuring corpse angle. You just take a AP view and put it into the software that will give you the calculation of corpse angle. Besides this measurement of corpse angle, it is in the coronal plane, but actual deformity which is causing disfigurement is the rotation of the vertebra. That assessment of rotation is done by looking towards the position of the pedicle that provides a best sense of degree of rotation. That is assessed by a method called Nash and Moe classification method, that is done in the same AP film. Just look to the pedicle, how it is moving. So if there is severe degree of rotation of the vertebra, the pedicle will start moving from convex side towards the convex side, concave side. So this classified, there are 4 degrees are there, and first degree is just moving towards midline from convex to concave. In severe rotation of vertebra, the pedicle moves across the midline to the concave side, and this is the real cause of deformity, hunchback and rib prominence in case of scoliosis. So assessment of maturity indices is very important, that give you idea about the remaining growth potential, and that can give you idea about the progression of the curve. What are the maturity indices used in scoliosis assessment? One is research grade, very commonly used. Same film can be used for assessing research grade. Tridentine cartilage, as I said, the pelvis must included in the AP view, that to show you the tridentine cartilage whether it is fused or it is open. Open indicates there is chance of further progression. Close indicates the maturity indices, maturity is completed, there is least chance of progression of curve. And if you don't have that clear pictures in the pelvis AP view, you can go for a X-ray of wrist looking to the distal physis, the radius and ulna. If that is fused, that indicates the maturity is completed, there is least chance of further progression of the curve. So this is picture, you can see research grade is very commonly used for deciding the progression of the curve. It starts, it is from the iliac assessment of the iliac apophysis. This iliac apophysis start from anterior superior iliac spine, and gradually it goes towards the posterior superior iliac spine. So when the whole apophysis appear over the iliac crest, that's the growth plate of the iliac crest. When it is completely appear, it is grade 4. So that you will see that how there will be radiolucent line. You look to this radiolucent line, there will be a growth plate over it, like radius, ulna, all long bones. The iliac bone has a growth plate also. So you will get a radiolucent line. This radiolucent line will not be visible when the growth plate has not appeared at all or it is completely fused. If it is not appeared, then it is grade 0. If it is completely fused, then it is grade 5. So 5 grades of research gradings are there, which indicates the progression of the curve. As the grade increases, the progression decreases rather. Grade 0, the chances of progression is more. So if you look to this curve, the percentage of patient going for increase of the corpse angle going for surgery with respect to corpse angle at research grade 0. So at research grade 0, if the corpse angle noted is 20 to 30 degree, almost it is you will get a corpse angle at maturity around 60 degree. So at research grade, if the corpse angle is more than 40 degree, it is definitely the patient is going for surgery. So this is relation. So this assessment of research grade gives a good idea that whether the patient is going towards severe progression of the curve, whether there is chances of patient to refer to surgery or not. Yes, MRI has also a role during our assessment system. In case of severe curve with progressive deformity, that warrants investigation with MRI. All of a sudden the curve is progressing. There must be some underlying cause, spinal cause. That time MRI is required. That you may give you about the presence of a T-third cord syndrome or a underlying syrinx. There are certain red flag signs. We should be able to detect those things. These things you have to immediately refer the person to the concerned specialty. If the patient is having severe pain, especially night pain with severe stiffness, there is sudden rapid progression with a previously stable curve. There is extensive progression in a patient after skeletal maturity. There is abnormal neurological findings. These findings are there, these are red flag signs where you need to completely evaluate the patient or better refer to the concerned specialty or a neurosurgeon. There are mathematical calculations for expecting the progression of the curve, scoliotic curve. That's called progression factor. This mathematical calculation of progression factor is Cobb's angle minus 3 into research grade divided by h. More is the factor, more chance of progression. Another factor is Harrington's factor, where this factor is Cobb's angle divided by number of vertebrae in the primary column, primary curve. So that's the Harrington factor. This factor says that the curve has a fair chance of progression when the factor is more than 3 in a child, if the factor is more than 5 in a mature patient, factor is more than 7 after maturity. There is still chance of progression of the curve. What is your objective of treatment? Prevent progression of the deformity, improve spinal balance, minimize deformity, improve cosmetic appearance, and reduction of pain. So coming to biomechanics of treatment, it has been biomechanically studied that the correction of the severe curve, it's the axial distraction force which works better than the transverse correcting force. We in our orthosis we are using a transverse correcting force with putting a pad over the apex of the convex curve, but that is not sufficient enough to correct severe deformities. So this mathematical calculation says that the axial distraction force provides most corrective bending moment for correcting the severe curve. And in this, and for a transverse loading, it utilizes mainly brace, which is mainly used for brace treatment. If you see here that the force applied here is divided into two halves, but the force, distraction force is completely full force is applying on distraction method, and this is applied in case of surgical correction using Harrington's rod or liquid rod fixation. But this is for the orthotic use purpose for spinal brace. But in this study says that there is a break-even point between this axial load and the transverse load. It seems that around 45 to 50 degree, both the force has similar action. So Scoliosis Research Society has guidelines shows 3 levels of treatment. The first level is observation till the curve is within 20 degree, and second level when the curve extends 20 to 45 degree of Cobb's angle, that is can be managed, can be stable, can be controlled by brace, and when the curve exceeds 45 degree may require surgical intervention. So observe the curve for the first, if the patient is presenting with the first time, young patient with the curve less than 20 degree, you call the patient every 6-month interval for observation. If the research grade is less than 5 and curve is more than 20 degree, research grade is less than 5 means there is further chance of progression of the curve. And if the Cobb's angle exceeds 20 degree, you have to observe the curve very frequently at 3-month interval. The second level of treatment is the spinal brace. The spinal curve with Cobb's angle 20 to 45 degree, the braces are indicated, and the mechanism action of the braces are traction, lateral deflection, and derotation. The principle is that they redistribute the mechanical stress across the spine, unloads the growth plate on the concave side, and growth stimulation leading to structural remodeling so that some extent curve can be corrected. The function of brace includes prevention of progression of the curve, improve structural alignment, reduce angulation and rotation, improve strong stability, reduce pain to some extent, and improve cosmesis. But the question arises, how much time a child should wear the brace? Is it 23 hours like a clubfoot brace? No, it is not possible, because these are all hard braces, hard laminate or polypropylene braces. Very difficult to sleep wearing the braces. So it has been advised at least use for 18 hours. Only for 6 hours sleeping purpose you can take out the brace. What are the factors look for orthotic prescription? Degree, pattern, and location of the deformity, progression of the deformity, age of the child, and what are the is there any associated etiological factors. These factors should be looked for before prescribing orthosis. There are different orthoses are available for scoliosis management. These are list of orthoses. This list shows about where the origin, development or indications, then type, material, everything is there. You can go through this slide, you can check. But commonly used orthosis in our system, in our institute, is mostly Boston brace, Miami brace, and sometimes Milwaukee brace. So this Milwaukee brace is a cervicothoracic lumbosacral orthosis, CTLSO. Since it is a above arm brace, the compliance is not that much of good. It has a pelvic girdle, which is the platform for the brace management. There is a neck ring. There are one anterior rod and two posterior uprights. Basically, they create a distraction force for the correction of the curve. Then there is a corrective pad at the apex of the convex side and axillary string. So these are the parts of the Milwaukee brace. These braces act by two forces, one vertically upward direction force and one laterally pressure over the convexity. So if you look to this picture, if you look to this picture, this is the laterally force applied through the pad over the convex area, and when this force is applied, there creates a distraction force. Since the curve has little bit flexibility is there, so this creates a distraction force for correction. So biomechanical, this is a very sound spinal brace for correction of a curve, and in fact there is no other orthosis which can correct a high thoracic curve or including lower cervical vertebra. This is the only orthosis you can address, but unfortunately this the compliance is very poor, as it is above since the girls more commonly affected, they cannot use dress with this, so poor compliance is there. The next commonly used orthosis is the Boston brace. Yeah, this is underarm brace with a posterior opening polypropylene brace that prevent progression of the curve with apeces below T8 level. Correction of the curve occurs in coronal plane and vertebral rotation occurs through pads and projections. So this has purely a coronal plane deformity, but studies say that some amount of rotation also can be corrected with this. The efficacy of the Boston brace has been studied by many authors, but this study shows that 49% of the curve remain unchanged. There is no further progression of the curve by using the Boston brace. 39% of scoliosis patient has a permanent correction of only 5 to 15 degrees. So basically these braces prevent further progression, hardly correct anything to a permanent curve. There are studies which comparing Milwaukee brace and Boston brace showed that Boston brace was more successful than Milwaukee brace irrespective of initial curve magnitude and skeletal maturity, especially for lumbar and thoracic scoliosis. I repeat, it is for the lumbar and lower thoracic scoliosis conditions. So Boston's always holds good. Other orthosis we use in our institute, Miami orthosis, where the curve is a little bit higher level at T6 and T7 level. This orthosis is better accepted because it has anterior opening and it has more flexibility, and there is the coverage on the concave side and the anterior side is less, mostly on the posterior side. So there is chance of the pad which putting pressure on the convexity side that has a movements or flexibility increasing towards the concave side. So this brace has better acceptance than other orthosis, other braces. So this study says that there is average initial correction of the Miami brace. Thoracic curve 36% can be corrected, and thoracolumbar curve 56%, lumbar curve 66%, double major curves average 38% can be corrected. The future of scoliosis bracing, yes, there need further more and more modification to the brace, appropriate bracing using artificial intelligence, some mathematical model calculation, 3D printing to give exact location of the curve, exact position of the correcting pad, then development of novel robotic spinal braces. These are upcoming, maybe in future that will come to have a better brace options. Therapeutic exercise have adjuvant function only. So yes, this has adjuvant treatment to the brace treatment. So the principle here is the core strengthening exercise, especially pelvic tilt exercises with supine with hip and knee flex or knee extended, deep breathing exercises, spinal extension exercise in prone lying position, balance and proprioceptive exercises. There are list of exercises given. The most important part is the posture correction. So there is always a vicious cycle because of bad posture and asymmetric loading. This asymmetric loading causes asymmetric growth, wedging the vertebra further increases spinal curvature. So you need to ask the patient to correct his posture. Different biofeedback mechanisms are used for advising the patient for correction of posture and symmetric loading. There are different mobilization and flexibility exercises are there. These different methods of exercise, Scrope's method, Scroth method, Dobo method, physiotherapy to scoliosis specific exercise method, scientific exercise approach to scoliosis method. Out of that, the Scoliosis Research Society recommends PSSE, that is physiotherapy scoliosis specific exercise method. This is recommended by Scoliosis Research Society. These are a group of exercise programs which are advised by them. So, like correction of the posture, then flexibility exercises, all these things. Surgery is the last option when the corpse angle is more than 45 degree. There are a number of procedures are there. Out of that, most common procedure is fusion of the correction of the curve and fusion of the vertebra at multiple level. So by using Harrington's rod or pedicle screw, there are other modalities also like growth modulation, gene therapy, and hollow pelvic traction. Rarely used, but can be a method of correction of spinal cord. So there are certain complications you may encounter: back pain in 80% cases, respiratory compromise, severe thoracic curve, disfigurement, the major complaint of the parents, psychological disturbances, and especially when the child grows to the marriage level, marital problem is the major problem for them. So coming to my last slide, take home message is for every physiatrist, clinical and radiological assessment of scoliosis must be very meticulous. Predict the curve, what is the extent of chance of further progression of the curve, knowledge about therapeutic exercise, simple therapeutic exercises which can you advise in the OPD practice, and decision regarding what type of brace need is required for that patient. You have to decide that, and of course parent counseling, because this is a mental problem, that they are very mental upset because the child, as girls, they are going towards marital age. The parent counseling is must as a treatment of scoliosis. Thank you very much.
Thank you, sir. It was a wonderful session. We come to know about the examination and the various red flag signs and the importance of research grade in surgery. Thank you so much. Any questions?
Yes, please. No, it is not about the age, it is about the curve. What is the extent of, because the earlier it was the surgery was indicated in adult patients when the growth is completed. But today we discuss about the adolescent idiopathic scoliosis. But think about the congenital scoliosis. There the curve grows very rapidly. So there is a, you might have seen the congenital scoliosis because of hemivertebra or a block vertebra. Hemivertebra means one side vertebra is growing, other side is not growing. So that time you have to take the child in early stages when the curve extends beyond 45-50 degree and child is developing any visceral compromise. There are growth modulation techniques are there. One can go for that. That can be done even before mature, the child get mature.
Neuromuscular scoliosis also, the child is not likely to improve unless he is operated upon.
No, for CP it is different. You have to take the patient as a whole, as the madam was telling. So if the deformity is a structural changes, structural curve is there, fixed deformity is there, causing visceral compromise, causing any red flag signs, those times may require, or else in CP patients it's better to manage by this. It's not because of structural cause. If there is an association of the, it's not necessary that no CP will have a scoliosis curve. Possible, but if the curve is because of scoliosis, then you have to think twice before advising for surgery.
Sir,
Yes.
I have one question. Sir, what is your opinion about using Mehta's index, I mean rib vertebral angle in
Sorry? Rib vertebral angle for the, again, for the congenital scoliosis, it is not for the idiopathic scoliosis. Last lecture I have shown that, but because of paucity of time I did not show these slides in this year. But that is meant for the congenital scoliosis, where you have to see that how much of the rib is overlapping over the vertebra, yes, and the angle is measured. Okay, so that is not for the adolescent idiopathic scoliosis.
Sir, I mean, I want to ask another one. Is the practice of bracing, matlab, casting in a congenital scoliosis or infantile scoliosis is in practice now or not? Matlab, they are doing axial traction and they are putting cast.
No, no, the casting technique is no more used. Yes, there is a Wellington brace is there, where the brace is applied over a traction table. First, patient is put over the traction table, distraction force is applied. Once the curve gets straightened, then a plaster cast is applied. That cast acts as a negative mold. Then you have to pour plaster into that to create a positive mold, and then you prepare a brace. That is used for the preparing the brace. But for treatment purpose, putting traction and putting cast, I think nowadays is not accepted.
Thank you, sir.
Sir, if like person came with after the puberty is achieved, like growth spurt is over, then there is any need of orthosis or not in that case?
Theoretically, there is no further progression of the curve, but practically the curve progresses as if you are not correcting the posture, biomechanics of the trunk, then they are likely to progress. And it has been seen that there is a mixed response on that regarding use of brace. If the patient, you are observing the patient, even after growth spot, patient is further increasing the curve, then yes, you can go for use of orthosis.
Thank you, sir.
Okay, I believe most of you are third-year residents. So, how do you take a mold for a booster brace? You have to take a mold for everything, no? Like you take a mold for AFO, you have to take mold for even for doing a prosthesis. So how do you take a mold for Boston brace? That's why it is very necessary to know, because that single question will tell me how much actually you do work at your department or probably the workshop.
For that reason, you have to know the trim lines of the orthosis, what is the lateral extent, what is the posterior extent, what is the anterior extent. Accordingly, you put your plaster cast, then prepare a mold, then prepare a negative cast, then prepare a mold. Nowadays, that can be limited by use of 3D printing, where in our institute we have 3D printing also. So we have also CAD/CAM, where first the scanning of the patient is done, then the mold is prepared by this 6-axis CAD/CAM. Over that, laminated or the braces can be prepared. So this nowadays, this casting is gradual wind up when there is availability of other technology like 3D printing and others.
So anybody, how to take a negative mold?
Sir, can I answer?
Huh?
Can I answer?
No, but we are taking it, so there is no need for you to answer. It's for everybody else. Anybody? Anybody knows how to take a negative mold for an AFO? AFO, just a question, not related to scoliosis. Now see, the thing is, most of you might become the first person to start a department, isn't it? And you have to know things inside out. Okay, so it's not like you just have to write a prescription and some Superman or Jinn will come and make whatever you want and do it. So you have to know things by hand. So until and unless you learn doing things by hand, it won't work. Similarly, as Henry was telling you about the surgery, so how many of you have done serial casts, like 10 or 12 casts for each patient? Have you done that? 1. 3. So people should not, those people who have not done casting shouldn't ask question for the surgery. So it's like that. So you should know it. Just go into your workshop, see how those guys are working. Because until and unless you learn the survival of the fittest, you will be eliminated. You have to understand that. You will be eliminated if you don't know. Thank you.